So, what brings the wind of change? Now, uh, it is a question of dilemma. Actually, who brought the wind of change? A lot of people thought that it is probably corporates who hype their technology and want to sell it to get more money. Some thought that probably doctors who hyped some technology to earn more fees. But in my belief, it is neither the corporate nor the doctors. It is the patients who ask for more. From 2000 onwards, the scenario of vitreoretinal surgery starts changing, and patients ask for early recovery, more predictable results, and better visual outcome. Think of those days where we try for skull buckling in all sorts of retinal detachment surgery. And that time, according to my school, that is SN, we used to say that chances of reattachment is nearly 70%. So there is chance of failure of 30%. And patients sometimes don't want to accept this, that Dr. Saab, मेरा केस failure में नहीं आना चाहिए. What will do after failure of SB? Then we explain that, okay, then options of vitrectomy is open, we'll go for. Some patients ask that why you are not doing the final thing at the first? Why you are doing SB, then failure, then go for vitrectomy? Then we are relatively conservative, means we are in the back foot because we are not so confident about vitrectomy in retinal detachment. But now things are changed from 20 gauge to 23 gauge, then 25 gauge, and this animation will show you the sutureless 27 gauge with a valve cannula, and here the incision is straightforward. You can see, for me, MIVS is not micro-incisional vitrectomy surgery. It is minimally invasive vitrectomy surgery. So, even though if you calculate mathematically the port size and add it all, the total scleral injury is much less than a microphaco surgery even. And nearly all surgery can be done in 25 gauge or 23 gauge or 27 gauge nowadays. It is a closed chamber surgery and it is a controlled diaphragm surgery. So results is very good, and postoperative look you can see much different from previous 20 gauge or skull buckle days. Now the newest generation machine which gives you lot, higher cut rate, better light source, endolaser system, automated viscous fluid injector or extractor, and measured gas injector. That means you don't have to measure whether this C3F8 is 14% or 15% or this SF6 is 20% or 21%. Constellation can do it for you. And you can jolly well see that cut rate, increasing cut rate is not a hype. Technically it shows that it reduces traction on the retina. Much more the cut rate, the traction on the retina will be much less. And the gauge change you can understand 20 to 23, then 25 plus, now 27 plus is available. And this is the series of instruments. This is 20 gauge, 23 gauge, this is 25 gauge. And now we are using 27 gauge plus, and whole spectrum of instruments. Even this one is a valve cannula. When you don't have to plug every time for putting your instrument, it is automatically closed from inside, and a closed chamber controlled IOP surgery. And another new parameter is added, that is duty cycle. Duty cycle is, see this video, the cut rate is 2500 in both the situations, but in one, vitreous is cutting too faster. That is actually duty cycle in maximum, and other, the duty cycle is minimum, so open time in the cutter is much less. So when you are very close to mobile retina, you should keep the duty cycle in the minimum, causing minimum traction over the retina. And the whole buckets of 27 gauge instruments now available. Initially, the initial days in 23 gauge, there are hindrance of instrument, but nowadays there is no hindrance of instrument. Greece have done everything for us. Means lot of instruments are available for 27 gauge for all purpose. So all surgery can be done. And availability of dual light source is very important. In modern machine, always dual light source is available. So if necessary, in difficult retinal detachment surgery like PVR or GRT or inferior break, you can any time you can shift over to bimanual surgery. And the most important change of wind for me is probably the wide angle viewing system. Without it, initial days we used to use that Payman's type irrigating lens, then lander, and then a Rolls type. Now the modern biome system is having multiple choice of lenses with even a disposable one. So you can change the lens also, and for every purpose you can change the lens, and you can do your base excision up to extreme periphery. So that wide angle viewing system is probably the greatest change. And accessories, you are having a lot of types of silicon oil even, 1300, 2000, 5000, 700. And in few days back, we used to talk that in probably inferior RD with GRT or recurrent RD, you need a belt buckle. Probably I will not propagate that thing now, because we are having heavy silicon with us, which is heavier than water, and it can support the taut retina at 6 o'clock position. Even you are having choice of PFCL also, HPF 8, HPF 10 is available, perfluorooctane, perfluorodecalin is available for difficult cases, and where there is intrinsic contraction of the retina, it is better to use decalin. And sometimes people ask like, okay, it is very easy to put 5000 CST silicon oil, but it is very difficult to remove it. For that, extraction is there, and this instrument make it very easy. In every case, we can use that. And finally, more demanding patient leads to more technological advancement to fulfill those requirements, and younger, brave, and skillful vitreoretinal surgeons will adopt them, give patient better and better results, and the wind of change will blow persistently. Thank you.
Thank you, Dr. Tushar.